Thank you for joining us for this interactive Facebook Live event presented by Siteman Cancer Center based at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis. Siteman is an international leader in cancer treatment, research, prevention, and education. Ranked among the top cancer centers by U.S. News and World Report, Siteman also is one of only a few U.S. cancer centers to receive the highest rating of exceptional from the National Cancer Institute. Welcome to today's Facebook Live.
Thank you for joining us today on our discussion to talk about breast cancer screening and therapies. Joining us today are two Washington University experts, both breast cancer experts at Siteman Cancer Center. We have with us today Dr. Lindsay Peterson, a medical oncologist and an assistant professor of medical oncology, and Dr. Cheryl Herman, a radiologist and associate professor of radiology. Thank you both for joining us today.
Thank you.
During this live event, we encourage our viewers to submit any questions that you might have in our comment section. Our experts will be able to answer those questions later. Dr. Peterson, let's start with the question for you. Women hear so much information about mammograms, breast cancer, and other related topics. We don't want viewers to tune out after this question or anything. There's a lot of great information ahead, but if they forget everything else that we talk about today, what's one or some of the most important things you would like for them to keep in mind?
Absolutely. So we're definitely going to talk about signs and symptoms of breast cancer, as well as ways to screen for breast cancer and even new and emerging treatments for breast cancer. But one of the most important things to keep in mind is that there are actually things a woman can do to reduce her risk of getting breast cancer. So certain things we cannot alter. When we're born a woman, when we get older, these are the two greatest risk factors for getting breast cancer. We can't change those. But there are a lot of things that we can do to help reduce our risk. Most of those center around a healthy lifestyle. So the general recommendations are to engage in routine, regular physical activity, follow a healthy diet, and work to achieve and maintain a healthy body weight. In addition, we want to avoid alcohol and avoid tobacco. To go a little bit more in detail of those things, in terms of physical activity, it's recommended that we get 30 minutes a day, at least 5 days a week, of some moderate intensity physical activity. We also want to follow a diet that is high in fruits and vegetables, high in whole grains, and really minimize or avoid processed meats and minimize our red meats. In terms of healthy body weight, we use something called the body mass index, otherwise known as BMI. And this is something you can calculate online. There are lots of online calculators. You just need to know your height and your weight. And our goal is to have a BMI or a body mass index under 25. So working to achieve those healthy lifestyle factors is something women really should strive for to reduce their risk of getting breast cancer. We'd certainly rather prevent a breast cancer than have to treat a breast cancer.
Definitely, and those are things we hope our viewers keep in mind today. Now let's welcome again Dr. Herman, Washington University radiologist at Siteman. Dr. Herman, screening, of course, is an important part of diagnosing cancer sooner when it's more treatable. What should women know about being screened?
Okay, well, thank you for that question. Screening, by definition, is looking for a disease or a cancer process before you can feel it, before you notice it, before your doctor notices it. So for breast cancer screening, we're trying to find things early so they can be treated much more easily, more cheaply, with less sickness and associated illness with it too, or any types of side effects from other more extensive treatment. So that's what we're looking for in screening. And we kind of stratify screening basically for like average risk women, which is the general population, and then high risk women. So for average risk women, we're looking at having patients come in, typically annually, starting at age 40 and going on till as long as the patient or the woman is in good health. For higher risk women, we're looking at maybe, in addition to annual mammography, then we will have additional supplemental imaging, such as typically MRI or magnetic resonance imaging.
Okay. What screening guidelines should we be aware of?
Okay. Well, there are about three big ones that, that basically are spoken about now. The main one that we follow here at the Siteman Cancer Center is the American College of Radiology's guidelines. So the American College of Radiology recommends that women get their baseline mammogram at age 40 and then get a mammogram every year after that. And as long as they're in good health, they can continue getting mammograms. So there's no cutoff for them. Okay? The second major guideline is a guideline through the American Cancer Society. And they recommend that you have a discussion with your physician and starting at age 40 to 44. And consider getting mammograms annually at that point. And then definitely starting annual mammography at age 45 to 54. And then at age 55, possibly switching to every other year. So it's either 1 or 2 years. Okay. And then continuing on for as long as you're in good health. And then the third and probably the most controversial of the three guidelines would be through the United States Preventative Services Task Force. And that came out probably about 3 years ago or so. And they recommended that you get a baseline mammogram at age 50 and then continue to get mammograms every other year and stopping at age 74. So that seems a little bit arbitrary, it's a little bit different. We know that many breast cancers, like 1 out of 6 breast cancers occur in women between the ages of 40 and 49. So starting with that, the USPSTF, or the United States Preventive Services Task Force guidelines, they start at 50, so you're missing this whole decade. And also when women are younger, their breast cancers tend to be a little bit more aggressive. So that last guideline is a little bit more problematic, and that's why we tend to stick with the American College of Radiology, or the ACR's guideline, starting at age 40 and continuing on as long as you're in good health. Okay.
A lot of information for people to take in, but the fact that you highlighted that starting at the age of 40 and continuing every year after that and making sure you speak to your physician is definitely a lot of information, but that right there is the key point that people will really need to take away. That's great. Thank you. For those who haven't been screened, are there common symptoms that they should be looking for?
Okay. So to start with, we used to recommend self-exams every month and also clinical exams from your physician at least every year. So that's not as much in the forefront now, because really with imaging we're finding things much smaller than something you can feel or notice on your exam. But I think it's still helpful to do a self-exam. So when you do your self-exam, notice a new lump, a new area of swelling, a new area of redness on the skin, a new area of itching, or maybe other skin changes such as dimpling. Those are changes that are significant and you should speak to your physician about. Other things that you would notice on your own physical exam would be nipple changes. So you might notice some scaliness, maybe a little bit of itching around the nipple as well. That's a little bit unusual, more than just having dry skin, and usually it's something that occurs on one side. And then also consider discharge. The discharge that is more problematic is discharge that is spontaneous. So it just kind of erupts on its own. There's nothing that you've done. Also, there are about 12 to 15 openings at the nipple. This discharge that we're interested in occurs in one area, so one of those openings. Okay? And then the discharge color is typically bloody, or maybe bloody and tinged with some clear fluid. So discharge that occurs around someone's menses, on both breasts, that's not as significant. Discharge that is whitish or yellowish, orangish on both sides, sometimes even greenish, that's actually not, that happens often, but that's not suspicious for us. So it must be something that is spontaneous, something that's bloody, and it happens at one opening at the nipple and also on one side.
Okay, that's great information. That's great for people to know. Viewers, please don't forget, if you have any questions, submit those in our comment section, and our experts will be able to answer those questions shortly. Dr. Peterson, it's not uncommon to hear about family members, sisters, aunts, mothers, and daughters who have been diagnosed with breast cancer. How common is this, and what should women know about it?
Breast cancer is actually quite common. So over the course of a lifetime, 1 in 8 women will get a diagnosis of breast cancer. So that's about 12% for just the general population, an average risk woman. What's important to remember is that those who have a family history of breast cancer, so their mother, their sister, their aunt, their grandmother, their risk is actually higher than that, so actually higher than that 12%. So there's a couple of things for people to make note of. In addition to the screening that Dr. Herman talked about, talking with your provider about your own individual risk. There are different things that can be done in terms of learning about you and your own practices, your own lifestyle, as well as your own family history that will really help define your individual risk. And that risk can be used to help guide some of your screening practices. As Dr. Herman mentioned, we really like to start at age 40, but there are certain individuals based on a combination of factors who might be at high enough risk to even warrant screening below the age of 40. Typically, those are women who have what we call an inherited gene mutation that increases their risk for breast cancer, but there may be other circumstances where, despite not having an identified gene mutation in the family risk is high enough that there might be recommendations for earlier screening as well. So I think it's important for people to, number one, identify their risk, and just to reiterate what Dr. Herman has talked about, which is the screening guidelines, as well as looking out for signs and symptoms of breast cancer. And as Dr. Herman mentioned, it's not always just a lump.
Okay.
It can be changes in the skin, in the nipple, the surrounding area. I think those are really important things to remember.
Okay, thank you. Dr. Herman, great strides have been made in the treatment of breast cancer, and the survival rate is better than it's ever been. Please tell us about some of the clinical advances you think are most noteworthy.
Okay, so probably Dr. Peterson might be better equipped to discuss some of the chemical or the medical aspects. I can talk a little bit maybe about imaging, just in looking for breast cancer. So standard, we used to have digital mammography, and we still do. It's all digital mammography. Now we've added tomosynthesis, or better known as 3D imaging. So essentially, it's like taking the breast and slicing it. And then as a radiologist, we can look through slices of the tissue. So especially for women with dense breast tissue, you can kind of just see a slice at a time, and then it kind of brings out any changes or any abnormalities in the breast tissue a little bit more easily. So tomosynthesis, or 3D, is one of the new, I guess, techniques that we use, newish techniques. And also MRI is significant. We've kind of increased or improved our sequences, and so now we're able to see more areas that quote unquote light up on the MRI examination. And we use MRI in addition to screening. We also are able to, like someone who is newly diagnosed with breast cancer, we also recommend getting an MRI afterwards too, to see if there's any other areas that may not have shown up on the initial mammogram study, or something that's on the other breast that was completely unsuspected. And also, I think another thing that we utilize would be breast ultrasound. The breast ultrasound frequencies are higher, so there's a lot of technical mumbo-jumbo, but basically we're getting nice, beautiful images, clear images. And although I bring up these other modalities, mammography is still the gold standard.
Gotcha.
So these are great supplements, especially for women that are higher risk, but mammography still remains the gold standard for breast cancer screening.
Gotcha. Thank you. And Dr. Peterson, to that same question, if you, as far as what advances have been made over the years in order to kind of get the survival rate to where we're at now?
Yeah, I think there are several things. So Dr. Herman talked on one, which is better imaging and more screening. That's certainly one key, identifying these cancers earlier so they can be treated at an earlier stage. One of the other things is certainly better treatments.
Okay.
So over the years, we have refined our use of certain medications. So additional medications have become available, and we have found better techniques or sequencing of such medications to really maximize how effective they are. So when we think about breast cancer, there are different types of treatment. Certainly there's the surgical treatment. For some patients, there's radiation treatment, and then there's the medical treatment. And the medical treatment is really dependent on the type of breast cancer you have. So whether someone has what we call a HER2 positive breast cancer, which is a certain protein that can be overexpressed in certain cancers, they have additional therapies available to them other than your standard chemotherapy. And those treatments have really improved survival for that patient population. Additionally, for patients who have what we call hormone receptor positive cancers, there are endocrine therapies or anti-hormone therapies that we use for those patients. And again, over the years, those have become more and more effective. We've looked at combining them with new and novel agents. And so these advances in chemotherapy and what we call the targeted therapies and the hormone therapies are things that have really helped, along with improved screening techniques, improve survival rates for breast cancer.
Thank you. Thank you both for that. We have some questions from our viewers that I'll ask. So Jim asked, since it's not recommended that men be screened for breast cancer, what should we look for?
Sure. So we can probably both touch on this.
Yeah,
I think it's really very similar to what a woman should look for.
Okay.
So lumps or bumps, anything abnormal in or surrounding the breast tissue of a male, as well as nipple changes. This may be something like Dr. Herman mentioned in terms of scaling or really severe dry skin changes. It could also be an inverted nipple, especially if that's something that's new. Okay. You also want to look for the surrounding areas. So under the arm, or what we call the axilla, there may be some lumps or bumps there. So I think it's important that men pay attention to their chest wall as well and look for some of those similar things that we ask women to look out for.
Okay. Okay.
And I would agree with that as well. And also, men can get mammograms too.
Okay.
So if they do find something, then they will be able to come in and get a mammogram, and we would, they would get compression just like everyone does, and we are able to see breast tissue or any abnormality that's occurring on the mammogram as well.
Okay, perfect. Thank you. So I have a question here from Deborah. What should the average time from biopsy to surgery be when surgery is the next step instead of chemo first? Does that...
I think that depends on a lot of factors. Yeah, it definitely depends on a lot of factors in terms of the type of cancer that you have. Some surgeries are carried out very soon after diagnosis. Some are a couple to several weeks later.
Okay.
And what that ideal time frame is really depends on the biology of the cancer, how fast growing it is, how urgent it is to get it out. And the other thing to keep in mind is that for a lot of cancers, we actually recommend giving the medical therapy before surgery. Okay. So patients who might require chemotherapy or even hormone therapy, a lot of times will administer those therapies before surgery. So the timing of biopsy to surgery is really dependent on multiple factors regarding the tumor.
Yeah, and I think, too, it depends on what type of imaging may be needed. So if we're looking for more areas, like we found this one cancer, we may be scheduling for additional imaging, so maybe another ultrasound or MRI. And so it just depends on when. I mean, usually here we can kind of get you scheduled pretty quickly. But if you need this additional imaging, and then if something is found on this additional imaging, then that would need to be biopsied as well, too. So we want to make sure that we found everything before we start going directly into treatment.
I understand.
Absolutely.
So Deborah had a second question. What are your thoughts on doing a bilateral mastectomy at the request of a patient when a lumpectomy may be sufficient?
Sure.
So I don't know if either one of you are comfortable.
I mean, that's a conversation between the patient and her surgeon. I hesitate to say because it's too personal and too particular to really answer.
So it'll be a question that individual would have to have with their physician just to determine what would be best for them. That makes sense. So I have another question here from Christy. Are there any new targeted therapies on the horizon for HER2 positive breast cancer that don't involve Herceptin. Okay.
Yeah, that's a great question. So there definitely are. So Herceptin, otherwise known as trastuzumab, was really the first targeted therapy that we had against HER2-positive breast cancers and really made a marked improvement in terms of survival for these patients. But since then, we have come out with new therapies. One that's on the market now actually combines Herceptin with a chemotherapy that's delivered specifically to HER2-positive cancer cells. So that's being utilized more and more, even in early-stage breast cancer, due to some recent data that it can improve survival in a subset of patients. There are also oral pills that are targeted therapies against different aspects of HER2-positive cancers, which are not related to the trastuzumab. So we've got at least 3 that we're using in early-stage breast cancer, and sometimes even 4 that are available. And in later-stage breast cancer, they're testing many new novel agents against the HER2 protein. So there's definitely things that have come out since trastuzumab that have improved survival, and there are things on the horizon as well.
Okay, thank you. Paula asks, if you have breast cancer in a second breast 10 years apart, is it considered a new cancer or reoccurrence of original cancer?
That would be most likely a new cancer.
Okay.
Yeah.
So, Dr. Peterson, that was all the questions that we had at this time. So, Dr. Peterson, we've already discussed advances in treatment of breast cancer, of course. They are the results of years of research into the disease. What recent research do you think will further advance breast cancer treatments in the near future?
There's a lot, I think, coming out. One of the things that people hear about a lot, sort of a hot topic in cancer treatment, is immunotherapy. So basically trying to train our own immune systems to attack our cancer cells as it would a common cold. One of the problems is our bodies don't see our cancer as foreign, and so they don't attack it like they would a bacteria or a virus. So there are therapies that essentially allow our immune system to attack those cancer cells. They've been very promising in other cancers, such as lung cancer and melanoma, and we're really working hard to see which breast cancers specifically might benefit from these immunotherapies. So I think that's one major area. The other major area is the targeted therapies that one of the viewers asked about recently. So we're always trying to make our current therapies better. And sometimes the way to do that is not switch therapies entirely, but to add another therapy that allows that particular medication to work better. So I think the immunotherapy and the targeted therapies are really areas to keep an eye on.
Okay. And Siteman, Dr. Peterson, Siteman and Washington University are known for research and clinical care. Both are important, of course. What is it about these institutions that make both possible?
I think there are a lot of things that are needed in order to have a really strong clinical and research program. I think what we have at Siteman and Washington University, which are key to that, are we have engaged providers and engaged patients. So we have doctors and scientists and staff who really are compelled to deliver not only cutting-edge care, but compassionate care. And we have patients that trust in our care. And when you have engaged patients who trust in the care you're giving, and you have engaged providers who really do want to do the best, that really sets up the ideal environment for really excelling at both research and patient care.
So those things are extremely key and important. Dr. Herman, you talked about the importance of mammography as an early detection tool. We also should discuss reducing one's risk. What can you tell us about that?
Well, I think Dr. Peterson actually went over that really well. So basically a healthy lifestyle, healthy eating, move more, get some exercise, decrease your alcohol intake, decrease or stop smoking. I guess one other thing we can probably mention is if you have a newborn, breastfeeding has been shown to be somewhat protective as well too. But also talking about risk, I wanted to mention, I didn't mention earlier, this is not something that you can actually change though, but African American women are at a greater risk of dying from breast cancer than Caucasian women, about 40% more so. So although we've made great strides since starting mammography, screening mammography in the 80s, and we've actually decreased by 40% decreased breast cancer deaths just across the board. For some reason, African American women are still dying more, and it's pretty multifactorial, but they tend to have what's called a triple negative breast cancer. So we're looking at the triple part is estrogen receptors, progesterone receptors, and then the protein that Dr. Peterson mentioned earlier, the HER2. And if those three are missing in the breast cancer, then we call it triple negative. Okay. And there are not as many chemotherapeutic agents that attack that type of a cancer. And black women tend to get that a little bit more often. Okay. Black women also tend to get cancers more often younger. So when you're younger, the cancers tend to be a little bit more aggressive, more assertive. So that's a difference too, and that's increasing the risk of cancer deaths as well too.
So what recommendations or guidelines, and I guess
Exactly.
that's what you were getting to.
Yeah. So now, and this has just been in the past couple years or so, that black women are now kind of considered high risk just by the virtue of being black women. And now it is recommended by the American College of Radiology to consider getting an MRI every year in addition to your yearly mammogram. So just, again, alternating every 6 months, getting a mammogram and an MRI as well, too.
That's great information. So we've run out of time. I'd like to thank you both for joining us today. Thank you for answering our viewers' questions and providing this important information about this topic. And thank you to our viewers for joining us as well on this important discussion about breast cancer treatment, prevention, and as well as risk reduction. Please remember to follow our Sightman Facebook page to learn more about upcoming events and about a large range of cancer topics. Thank you so much for joining us.